Mission and margin is the business of healthcare. Thanks to our sponsor MedChat, providing live chat, bots, and text tools for a modern digital front door. See medchatapp.com. Filmed in partnership with the Insurance Managers Association of Cayman, host of the Cayman Captive Forum. One of the most promising opportunities to elevate healthcare mission and margin, a topic I'm so passionate about, is at the intersection of population health risk and insurance captives. This interview with Scott Hawig, Senior Vice President and Chief Financial Officer for Froedtert Health, captures the essence of why this intersection is so enormously important. Our thanks to MedChat and the 2019 Cayman Captive Forum for making this interview and the rest of our 5-part series on population health possible. First, a 2-minute backgrounder introducing Froedtert Health, defining population health risk, and describing insurance captives as a business concept. That's followed by my 20-minute interview with Scott Hawig, edited for length and clarity. An organization takes on population health risk by contracting for a portion of medical financial risk in a group of attributed lives. Like any other business risk, organizations may accept, avoid, transfer, mitigate, or exploit population health risk. An insurance captive is an insurance company formed to enable any or all of those risk management approaches with the parent as the sole customer. It is a business structure, a risk management organization, a financial concept, and a governance model used by approximately 75% of U.S. health systems and large physician practices. Captives provide better control over insurance expense and risk management. Population health risk is an emerging risk being managed through captives. Froedtert Health is a $2.4 billion health system serving eastern Wisconsin and part of a regional health network with the Medical College of Wisconsin. Based in Milwaukee, the network operates 5 hospitals, numerous outpatient and ambulatory clinics, and employs 2,000 physicians. In addition to providing care for more than 1 million patients under traditional fee-for-service contracts, Froedtert serves 350,000 attributed population health lives. This is approximately 17% of their primary service area, placing Froedtert among the top quarter of U.S. health systems, with Kaiser Permanente at the top of that scale. The punchline from this interview is the impact scaling population risk and deploying an insurance captive have had and will have on Froedtert's financial sustainability and, more importantly, the health of millions of people from Wisconsin and across the Midwest. Scott Hawig, thank you so much for joining the business of healthcare today. Your organization, Froedtert, has done some really interesting work delving into population health and taking on population health risk. Tell me why.
Broadly speaking, from a population health perspective, it's good for us to continue to find the best use for the assets we have and avoid building new. We think it's best for the payer, whether that be a government, an employer, or the member or patient themselves in terms of being able to move as much care as possible to a lower cost setting. And then ultimately we think it's better for the community in terms of accessibility, ease of getting in and out, lack of having to deal with parking structures and all those types of things, big campuses to navigate where you're going. We think the experience is better as well if we can continue to push on that. So from a very broad perspective, we think population health is the right answer. I'd say the last piece in addition, and maybe we're fortunate relative to the volumes we have, I think broadly for the community, for both the government and the employers who are paying for the vast amount of care, this idea of, for years, arguing over unit rates, and the ramifications of that, whether it's price estimation tools that people have developed, insurance company conversations about what's your discount, and I'll pick an insurance plan, maybe less based on service, more about discounts. Have we tackled getting the community healthier in a right way? And the idea with population health, I think from a very high level, from a finance perspective, is that it's a way to start to change the funding model for healthcare in the U.S. so that you're paid based on a population you serve, not on the per click or the per transaction way. So I think those are broadly, we're believers in that. We think that's the right way to do. We think we have assets that work well in that space.
You're in a highly efficient state for healthcare. Talk about that.
Yeah, I think Wisconsin has earned a reputation. I'll say the state as a whole, all the healthcare providers in the state have done a really good job over time in driving utilization out, of being responsible about how utilization is ordered and diagnosed. And so I think that comes from, quite frankly, all the providers in the state. It isn't certain parts of the state are certainly better than others, but the state as a whole is rated well. I think that's culturally driven, good practice of being thoughtful.
Those Swedes that populated Wisconsin originally, right?
Some version of German, Swedes, Irish have combined to say, that just show the right approach. Arguably, culturally, we do that on all things, not just healthcare. Healthcare was a part of absorbing that. So I think that's been part of it. Hopefully, those who practice care in the state have also added to that in terms of driving quality. I'll say as a whole in the Midwest, you have some of the most highly thought of efficient providers. I'll include Minnesota and Illinois, and they're big brand name providers in that area, all that have kind of highly been respected in terms of how they've driven thought around care, what care was appropriate. And so I think it is everything to do with culture.
Now you, at the end of the day, in your leadership role, restructuring, cost efficiency, that's job one. Is that fair to say?
I do, and I come at it with probably 20 to 25 years of experience now. And why do I bring that up? We've gone through, and I think others who would listen to this would say, every 5 years we've done these big cost restructure projects. And we've looked at how can we incrementally increase productivity, how can we take a little bit out of supply spend, how can we look at pay policies, and what I'll say is we've done the easy work, the low-hanging work at this point maybe 2 or 3 times over the last 15 years. The question now becomes, have we exhausted that, and do we have to get more transformative? And that's where you get into utilization, standardization of care, variations in care. How do you take some of that cost out? Quite frankly, that holds promise. While that is clearly much harder, the path on how to do that, less obvious, that holds the opportunity of much bigger numbers in terms of the amount of cost that is possible to take out if we're innovative or transformative and are able to do that. So that's the promise right now.
You've taken on a lot of population health risk. Talk about that risk pool. What makes up your risk pool?
Yeah, I'd say we've taken on in a number of factors. First and foremost, we approached all the significant national payers in our market, the Uniteds, the Anthems, the Humanas. Within our commercial, particularly our Medicare Advantage and our Medicaid contracts with can we take a risk component that started as is, I think, common across the country with taking more of a shared savings approach. How do we outline value type payments and cost benchmarks? That has progressed into taking downside risk as well. And so our first option at this was to go through all the existing payers and say, okay, how can we take risk? I'll add into that, from a governmental program perspective, Medicare, we're a state and particularly a provider who's opted to take risk on CMS. Before they were just mandated bundles like the CJR bundle. And so we've really taken, I would say, a comprehensive approach across payers to do that. We expanded that back in the 2014 era into buying into an existing health plan. And so we are now a 50-50 joint venture partner in a health plan, again, largely Medicare Advantage, commercial business, a little bit of self-funded to that, and now the ACA or exchange business. And then lastly, probably a year after that, maybe somewhere in the 2015, early 2016 era, we started a third-party administrative company, so TPA, clearly sole focus on self-funded business. And so what we'd say is we are building assets or building the tools in order to continue to take on more risk, in addition to just signing contracts with existing payers to do that. I'd say the last piece of it, why all those approaches? Clearly, it's a way to get more population and risk contracts faster in order to touch people. And then I'd say, secondly, each of those has different ability to implement or a test pilot different strategies, whether they be pricing strategies, whether we move to technology and the phones that we all carry in our pocket, how I price them, what I can offer on them. That's easier to do in a TPA or a joint venture health plan than it may be to go to United or Anthem and say, hey, let's use a Froedtert app to do that. And so each of these avenues gets us exposure to different members, but also probably allows us different pilot programs to test on how to drive population health strategies we may have.
And approximately how many lives do you estimate are in a true risk arrangement?
Yeah, the easiest to talk through, I'll start from the back. And the TPA has about 25,000, including our own membered lives. Okay. The health plan has about 125,000 that we're a joint venture in. And then if you add up where we take risk, I'll say our attributed members in CMS programs, United, Anthem, Humana programs, that's probably another 150 to 200,000 lives that would be in focused programs or focused value payments that we have through those organizations.
So easily 300,000 or more lives altogether.
Yeah, in some, and we do track that. Your question's a good one. That is one. We look payer by payer, what would be our attributed lives and how many that we have in this quadrant. Clearly, each of those, maybe in isolation, perhaps the national payers is a big enough number, but in isolation, you get nervousness about kind of too small.
Right.
So to your point, 300,000, 400,000, 700,000, if we can accumulate them, regardless of which approach they're coming through us, gets more data, gets more statistical relevance, and certainly as we talk about captives and insurance and actuarial writing, gives us more validity in data.
And that's a great jumping off point. You have a captive began work on it 5 years ago, formed 3 years ago.
Yep.
Talk a little bit about your decision to form an insurance captive.
Yeah, I'd say initially when we take a strategy like this to a finance committee or a board, particularly in light of captive usage in a healthcare provider for the U.S., it's not a new topic 3 to 5 years ago. The very first focus is what's the efficiency in doing that? We're a large self-funded entity, whether that's med-mal, property casualty, or our own medical stop loss. There is efficiency that's been proven over time in order to use a captive. So the initial conversation was around cost efficiency, one of these cost restructure projects that was always pinged. Second, though, and arguably more important going forward, is the idea of, I'll say, focus around risk management. So it's one thing, I'll say, to cut out an insurance middleman on things we were self-funded anyway. Most importantly, it's how are we driving the incidents and the cost of each incident. And so does the ability of us serving as a captive give us better data and more focus on workers' comp incidents? And so if there's needle sticks or there's falls or there's back injuries and that trend is going up or down, we now have very timely data to go back to our operators and say, in a certain unit we see needle sticks rising. There are best practices in how to manage needle sticks. We're going to roll out that education. If we're insured against that, not that motivation isn't there if you're a third party insuring, it's there, but the timeliness, the focus around doing that is much greater. And the last piece I'll say about focus, because I've mentioned that a couple times, is historically, the purchasing of insurance was spread out. So HR your human resource department may make the decision around medical stop loss. You have a risk management team that works with operations, probably on property. You may have an occupational health unit that makes a decision on workers' comp in partnership with HR. Finance lingers in the background. General counsel or legal lingers in the background. The question is, were you making real efficient decisions in total risk exposure versus isolated units? What the captive does, when I say focus, the captive brings focus, you now have, at least for our captive, you have finance, general counsel, risk management at the table in terms of the directors of the captive. And one of our largest missions is to take the data we now have access to and bring it back to ops to say, okay, here's the incidence rates, either on a PM or per employee, whatever the right metric is for the line of coverage, per automobile, if we're talking about liability coverage. Here's the incident rate, here's the cost per incident. It's getting worse in some cases. What are we doing? What education we can provide? Whereas historically that could have been spread out in the organization.
There's a phrase that you used earlier as we were prepping for this, the idea of creating organizational muscle or organizational capabilities. Talk a little bit about that.
Yeah, so if we make a very broad connection then of a captive to some of the risk and population health strategies, a way to look at the captive is that we are building organization muscle, infrastructure, tools in order to be a population health leader or executor later in the future. And how do you do that? Whether it's adjudication of claims, whether it's using data to make predictive modeling of incidence rates, whether it's just the core management of risk. Do you develop the tools and technology to early flag when something is going different than the premium you had set out or the expectation you had set out? What action, whether it be education, whether it be financial remedies, do you start to take so that you take action in a first quarter or second quarter rather than wait for a bad year and then just handle through a premium? It's muscle memory like that, the actuarial sciences, the handling of data, the deciding when to settle, when to argue, what's the merit of a case. That muscle memory will be duplicative, we think, to population health. Those are the types of decisions you'd have to make. Those are the actuarial sciences, the types of skills and capabilities you'd need to succeed in population health at a later date as well. So that's what I mean when I say kind of the muscle memory to continue to take on more.
Is there a moment that you see in the not too distant future where, as an organization, more revenue and EBITDA comes from health than from health care?
Yeah, the right answer to that is yes. Where we always get in trouble is to predict a time frame to do that.
Yeah.
And I suspect some of my counterparts, right, finance folks are notorious for saying, yeah, that's going to happen in the next 2 or 3 years, and then it takes 5 or 7 or 10. Directionally, I think the answer to that is yes. The speed, market by market, state by state, product by product. Clearly, we have Medicare for All type conversations happening on a national level. Those types of things will either accelerate or decelerate some of that conversation, but directionally, yes. Hopefully, through more innovation. And what I mean by that, I will loop this back to Medicare for All. Yeah. Taking an entire population and putting them through that channel, I think, is risky. As let's say I'm a community member or a general civilian, because it is experimental at this point. Where can we take either willing employers and do it through the self-funded model?
Yep.
Certain segments of the government business. How do we learn a little bit more about how this is going to work? The behavioral science of how do people use it? Where to set copay, patient responsibility loans. We'd be best to do this at some point of experiment. We have a lot of different patient profiles in terms of doing the experiment over. So how do we find 2 willing partners for another willing partner? And what's the right mix and the right size to pilot that?
As you think about your captive, have you used your captive as a vehicle to invest in things in the operating business to improve quality, safety, cost restructuring? Has that been a strategy that you've employed?
Yeah, as you mentioned, our captive now, the idea is about 5 years old. The execution in terms of premium writing is about 3.5, going on 4 years old. And so what I'd say is our first 2 to 3 years was very busy in terms of adding lines of coverage. Sharpening our teeth in the business. Certainly within the last year, as we become more stable about what lines of coverage are in, and we've built historical data now.
Yep.
More and more our conversation is around that, and to your point, whether you call it a grant or an investment by the captive, we have started to make those investments in certain roles, skill sets, functionality, training, education programs, all at an operator level to drive the incident rate. So if we go back to that workers' comp example, if we've identified a problem around a certain nurse floor where there's falls or back pain that's more of a problem, the captive has taken now a more active role in saying, okay, we'll fund education or we'll make an investment on implementing these 3 best practices. Maybe that's a coordinator, maybe that's an educational program to purchase, whatever the tool may be. And so we have started to make those investments for the captive, and those all have relatively quick ROIs or payback.
And do you think that, so I believe that one of the strategic values as a captive is the ability to make those decisions and investments and do it faster than what would have happened in the traditional financial decision-making process. Those CFOs are very difficult to work with sometimes as operators. But does that resonate with you, that idea of the strategic value?
Yeah, I don't know if I'm supposed to, as being a CFO, I'm supposed to agree with that, but yes. I think that has been our case, where we have been more nimble. I think for the CFOs, I'd say it matches expense and revenue.
Yeah,
so if
you're very tight.
If the captive is getting the expense because it's taking the risk, they're motivated to make that investment.
Yep.
Where an operating entity who's insuring that risk probably has less motivation, whether you'd say it's because of the bureaucracy of a parent and an operating structure, or just motivation itself to make that investment. We have found that to be the case. It's been much more nimble. The payback to the captive to date has been very strong, which builds momentum into doing more of those investments, continuing to look for those investments. It's worked from an operator perspective because they, as the user, feel like they got more in-ear attention. So rather than waiting for a budget cycle, or rather than waiting for a problem to get so big, and then a captive or a risk management arm or one of the functional units of the system saying, hey, operator, look what problem you caused.
Yeah.
Now we're $1 million off on workers' comp and you haven't done anything about it. What they feel like is they got more attention sooner, right before a problem got bigger. So to that degree, they're happy. They got more resources. They didn't have to navigate through an FTE request process or a capital request process to do that. So to date, it's worked. I'd say we are as diligent in the captive about making that decision to add, but we have the ability to add it sooner. Identify the problem sooner.
Do you see a role for the captive in population health risk, in that medical risk associated with population health?
Yeah, I do. First, because of the muscle memory. You're gaining some of the skill sets we think we're going to need for population health. So that's an easy one. I think second of all, it is one of the lines of coverage we're looking at. I mentioned as we've taken downside risk with the national plans, including CMS, what they ask for, what is typical as one of the requirements of that program, is for us to insure that risk. So CMS comes to us and says, okay, you want to be an MSP ASO program, MSSP program. You're going to have exposure of 5 million or 10 million or 15 million of downside risk. We don't just take your word for it that you will fund that. You need to have insurance or a way to fund that. Today we buy insurance for that. Perfect use for a captive.
Yep.
Why is that the case? That tends to be volume in our campus.
Yep.
So we have direct control over the utilization, as we talk about the state of Wisconsin and kind of our focus around that. Perfect use for the captive to take some layer of that risk, preferably kind of the first layer of risk on that. And so that is a line of coverage we will be looking to add. And again, you see how this then cycle, it becomes now easier for us to take by quantity more risk with payers, and perhaps even by retention level, more risk with individual payers if we have that captive as a backstop. And so again, access to data, focus, all can be driven through there.
It's a virtuous cycle. You really, the captive really is one of the places where the mission and margin of healthcare completely align.
Correct. And in fairness, I'm talking very optimistically today in a world where everything goes well. The same can be said when there is a bad year. So the provider feels the bad year. The captive would feel a bad year. How are we, and I talk about the muscle memory, how are we funding that? What is our thoughts around capital allocation to make sure we can live through that bad year? How often should we expect a bad year to happen? Do we have the tools in place where we're in the bad year and we're starting to take action to make it less bad? Then get to the end of the year when it's really, really bad. All those things, I think a captive plays a role in all of that. And so we have to prepare ourselves for it won't always go perfectly.
Yeah.
We will, when we say downside risk, there will be a down year. Yeah. And that year will hit both the provider and the captive at the same time. How have we thought about financing that?
So if you could go back and talk to yourself yourself 5 or 7 years ago, what are the lessons that you've got today that you'd like to share?
We had a board meeting this morning at our captive and headed into year 4. What we'd say has been very successful to date. So I should probably say we should have done this sooner, right? So you gave me the 5 to 7 year window, and so I should have said originally when I came to Froedtert, we should have implemented this objective sooner. So that's an easy one. Generally what I'd say is the ability to move faster on the focus element. We've spent a better part of 3.5 years adding lines of coverage. That was absolutely, to date, that's been the absolutely right decision. Our way of thinking about how we've diversified the benefits of funding over and now a diversified risk portfolio has all worked out well. The question is, could we have moved faster through that? So we are in optimization state. The part of the conversation you and I were talking about in terms of taking data back to operators, driving down incidence rates, driving down the cost per incident, that's the gold. And so we're doing that work now. We feel good about the speed at which we got there, but the industry is a little chaotic right now. And so I think if that muscle memory translates into execution, we'll decide, in some way, help decide some of the winners or losers. And so the ability to get there faster, the ability to get to the meaningful part now of making those investments to drive operations, you always feel like with the great return that's been there that you wish you could have done that sooner. But,
yeah, makes sense.
Generally continue to feel very, very good about the direction, the way we went about doing it, the way we've added lines, the lines we've added, we feel very good about it, all in preparation to continue to do more.
Well, Scott Hawig, thank you so much for joining the Business of Healthcare today.
Thank you.
Thanks to our sponsor MedChat, providing live chat, bots, and text tools for a modern digital front door. See medchatapp.com. Watch, listen, or read Business of Healthcare interviews at bohseries.com.